reproductive, at least for sure, is not going to be that hard. And I'm talking about MBA. You know the stuff we talked about it, the stuff that got quiz, no problem. Pathology, you know, it's very similar stuff. So, you know, the fact that I'm a pathologist, I'm always looking at it that way. You know, what was the discussion I had in a small group pathology, and always I have that in my mind when I look at the questions. Same way, if this is a case of the sexually transmitted infection. We already talked about this. This is talking about the syphilis. And we already said what is the presentation. And I just want to show you, you know, what you see in the picture. So this is the dark field microscope. This is actually antibody antibody spirochete. You can see highlighted. And remember about the shunter. So remember painless, you know, ulcer. Don't forget about the plasma cell. Don't forget about the arthritis, endarthritis. This actually is the reason for all this complication you get, especially even in tertiary syphilis. Most of them is due to this, you know, ischemia due to the endarthritis. So arthritis or endarthritis obliterans. Again, shows the same thing. You can see plasma cells here very nicely. You can see these capillaries pretty much all kind of occluded. It's all kind of, you know, thickened because of endothelial proliferation. At the end, actually, this become endothelial fibrosis, produce obstruction, ischemia, and all of those symptoms. Maculopapular rash. If you do biopsies, it's going to show you same thing. This is secondary. Remember, so we talk about that. In secondary is the actual situation. You're going to see a lot of proliferation of these spirochetes. A lot of time, actually, when you treat them during the secondary, or even, you know, sometimes primary, when it's extensive, you get a penicillin. Actually, the rash sometimes get worse. What we call that? What is that? Jerry Hexheimer, right? Is a situation that actually these spirochetes die and release a lot of, you know, material, and then actually produce a rash. The rash get worse. But anyhow, that's not related to small group. Don't worry about it. You know, just you can see lots of spiral. This is a situation when you do actually your test, your RPR or your specific, they're 100% positive. You know, when you do RPR or VRL in the, you know, primary, about 80% positive, okay? So it's still gonna be a possibility of even false negative. So also false positive. Remember, when you do those tests, those non-troponomal tests, it can be positive in glucose, can be positive, you know, antiphospholipid. We talked about that, and we always said you have to confirm it with another test. But in the secondaries, you know, you're going to see a lot of spirochete. There's going to be both tests, going to be positive, almost 100%. And again, you know, can be easily diagnosed. Now, tertiary is the one is a problem because you do those, you know, non-specific tests in tertiary, they're not going to be positive. So again, if you think about tertiary syphilis, you want to go with a specific test. And sometimes tertiary syphilis not necessarily comes after 5-10 years. If it's a patient is an HIV or AIDS patient, may come very fast. So it may come, but the neurosyphilis is just, you know, as a presenting symptom. So in that situation, you want to start with the more specific test. Okay. The only situation you can use VDRL is CSF. So CSF in tertiary syphilis, the one that is kind of asymptomatic tertiary neurosyphilis, you can use the VDRL, which is positive. So this is herpes. We already talked about it. Painful genital ulcer. Remember about the multinucleation. Remember about the type of inclusion. This is a Koji type A inclusion, the one that is kind of pinkish red and halo around. There is another type of inclusion that is kind of ground glass. I think the next picture shows that. So you can see both of them together. Another feature that's kind of typical is the chromatin. The normal chromatin actually push the side. So you can see actually the chromatin, these nucleus envelope or membrane become a little bit thickened because of margination of chromatin. So we always talk about these 3M, margination, multinucleation, and the type of multinucleation, you see all the nucleus molding, so molding cell. This is vesicle or pustula, so you can see multinucleation here. These are kind of ground glassy looking, so that's actually you see with the herpes. by the way, the psychiatric effect of herpes, remember the test is Zang test, which is, but it's not specific for HSV2, for example, but you see it mostly here, can be herpes, type 1, can be a BCV, varicella, all of them going to show the same. However, presentation with this in genital tract, that pretty much goes with the herpes. PID, so you can see this is a tubal ovarian abscess. We're talking one complex mass. Fill, if you look at the histology of this is a fill with the neutrophil, actually fill the lumen. So as soon as you look at that picture, you were thinking about chlamydia, you think about the GC, and when you look at this is an acute, this is the one comes with the tenderness, pain, vaginal discharge. Every time you're dealing with that, there's two differential diagnoses. First of all, if it comes with the pain and tenderness in the pelvic pain, see if the patient have a purulent vaginal discharge. You have to think about that, but always think about it. Sometimes with pelvic pain, you want to be sure this is not an ectopic pregnancy or anything like that. On that situation, you are not going to say purulent vaginal discharge. You're going to say some bleeding, okay? But and remember, they are not going to tell you the patient pregnant. Because if they tell you pregnant, that's going to be easy. And lots of the time, they don't know it's pregnant. So it comes with that, whether it's bleeding, pelvic pain, adnexal pain, and go from there. So next case is a case of the, again, sexually transmitted infection, but we're going to talk about both chlamydia and complication, infertility, ectopic pregnancy. This is a pap smear. You know pap smear is the single most effective cancer screening, actually. Cervical cancer is number 13 in cause of cancer in the United States. And actually, from all three different top cancer in genital female reproductive cervix is the least common one in the United States. You go outside the United States, actually, it's a leading cause of cancer there. And every year in board, actually 500,000 new cancer cases, cervical cancer cases, half of them die. Very aggressive disease. Even in the United States, when you actually diagnose cancer, cervical cancer, 50% means it never had a pap smear. Because if they had a pap smear, you pick it up early and you treat it, with the cone and excision. So when you do pap smear, you sample ectocervix and you sample transformation zone. So the way you know it's a transformation zone sample is two things: see metaplastic squamous cells or endocervical cells. Because if I see endocervical cells, means the brush already passed through that transformation zone and got to the endocervix. So that's very important. If I don't see these endocervical cells or squamous metaplasia, which I don't have a picture of squamous metaplasia, I'm going to call a clinician and say, this is not a good sample. You didn't sample the proper place because that's the area most of the lesion start. So pap smear. So we said, if you look at here, that's a normal squamous. This is endocervical. I want you to look at these cells. These cells, when you look at them, in compared to normal squamous, they have much less cytoplasm, and they have a higher size nucleus. And nucleus is dark, have a irregular nuclear membrane, so these are dysplastic cells. As a matter of fact, this is a high cell. Now, if you think about it, how are we going to make a diagnosis of low cell in the pap smear? Koilocyte. If I see koilocyte in pap smear, it's low cell. If I see cells like these with the high NC ratio, irregular nuclear membrane, hyperchromatia, that's a high cell, okay? Every time we make a diagnosis of abnormal pap smear, low cell, high cell, anything, goes to colposcopy and biopsy. And next picture shows the biopsy. So nicely in biopsy, I see whole thickness. It starts from basal cells, goes up. Now, every time we have a low cell or CIN1, we're gonna see these dysplastic cells that involve the lower 1/3, okay? And then when it goes more than that, it's going to be a high cell. So previously they were used to say, and you may see it still in the book, lower 1/3 CIN1 goes to 2/3 CIN2, or goes more than that, they call it CIN3. If it involves all thickness without no maturation, call it carcinoma in situ. And after that can invade, can break down basal cells, basal basement membrane, and become invasive. Now, think about the pap smear. What the pap smear does, if this is a cervix, pap smear just sample these. You cannot, with the brush, goes here. You cannot actually cut, with the brush actually destroy. So pap smear usually sample these kind of upper portion. So for low cell, the only things I'm going to see in pap smear, I'm not going to see a 1/3 that is dysplastic. I'm going to see koilocyte. So remember, low cell have a feature of low cell dysplasia in lower 1/3. Like that, and then koilocyte. The coilocyte is the only things I'm gonna see in upstream. So as soon as I see coilocyte, I know it's a low cell. But high cell, when I see these cells goes up, I can see high cell in the pap smear. So I can make a diagnosis. That's the reason I said, well, coilocyte in the pap smear means low cell, because I cannot see lower 1/3. The only way I can see it, have a whole thickness. Now, what's the next step in this case? If you had it just lower 1/3 or just coilocyte, which is a low cell, you follow it up. But in this case, these mitosis, these atypical cells, those upper 1/3, this is actually CING, or if you want to call it high cell now. And next step is cone. Excise these. So part of the ecto and all endocervix, including transversal zone, we just excise it and take it out. You know, outside of cervix is there, okay? And then we could just cut another cone inside the cervix and take it out. This is the first step. Every time you have an HPV infection, this is what you see first. You're gonna see, and that's very important, lower 1/3, see that dysplastic epithelium sometimes? Sometimes you may not see it, the only thing you may see is a coilocyte. But you can see coilocyte, you can see lower 1/3 involved. We call this flat condyloma. You know, regular condyloma, you can see it in the area, other area in the body, but which is a similar kind of morphology. But in the cervix, usually they're flat, they're not kind of finger-like projection like that. But hallmark of condyloma HPV infection is coilocyte, right? So you can see coilocyte, you can see these abundant here. And coilocyte is a reproductive form of virus. It's a virus using squamous epithelium to make more virus. So these are the reproductive portion of the feature of virus. And these are usually kind of mature squamous cells, abundant cytoplasm. And then they have this halo around the nucleus. The way they're gonna ask you in the coilocyte, they're not gonna tell you what is, maybe show you a picture, but always the wording for coilocyte is racinoid nuclear membrane and hyperchromatia. Racinoid means irregular nuclear membrane, hyperchromatia. Okay. I see Dr. Ramadan here, so kind of very behind. So, oh no, it's 342. So that's a cervical cancer. So when you see a lesion, there is no question here. You're not going to get the actually lesion like that with just a dysplasia or low-grade or high-grade dysplasia. When you see actually lesion like this is the cancer, and this is the one that usually you get post-coital bleeding and all those we talked about it. Then we know it's a cancer because you see surface is a carcinoma in situ, but here you can see broken basement membrane invading to the stroma. This is the invasive squamous cell carcinoma of the cervix, so you can appreciate that. Remember, this is a kind of aggressive disease. Remember how they're going to present. They invaded to all the other structure around. We already talked about PID, a little bit about torsion of the ovary. And this torsion usually, where is the blood vessels to the ovary? It comes from these, actually from here, yes. And then when is the torsion actually, when twist, you're gonna have actually venous blood supply closed, but artery still goes. The same way that actually you had it with the testis. So when you see torsion, again, it's gonna be hemorrhagic, dark like that. Now, another thing is ovary is a little bit different. You may see torsion when there is ovary for any reason becoming large. A lot of times you see a torsion associated, for example, with large cyst. You see it in polycystic ovary, you can see it with teratoma. So anything that makes the ovary large can produce torsion. In this case was a PID, and you can see that. So no problem here. What's the definition of endometrial hyperplasia? We already talked about the hyperplasia, cancer, risk factor for endometrial cancer, obesity, hypertension, diabetes. We said polycystic ovary, we said glandular cell. Definition of hyperplasia means increased gland-stroma ratio. Normally should be a 1-to-1. So if you look at here, there's not much of a stroma. It's all gland, look like back to back. Now that's the definition of hyperplasia. Hyperplasia based on architecture can be just a small tubular gland, we call it simple. If they are irregular, kind of budding and more crowded, we call it complex. So based on architecture, we have simple and complex. However, simple and complex is not very important in terms of determinant factor for the cancer. The most important thing, as I said, is atypical. So start with the hyperplasia, simple hyperplasia without atypical, later become complex hyperplasia,